Up next, House File 1005. This will be a joint presentation from Representative Bierman, Representative Baker. And as they're making their way in and getting settled in, I will move that House File 1005 be laid over for possible inclusion in a future omnibus bill. Welcome to the committee. Whenever you're ready, please introduce yourself and present your bill.
I'll jump in. Just good morning, members, and thank you for having me. I'm proud to co-present today with Representative Bierman, who's going to start it off. Thank you.
Thank you, Chair Schumacher and committee members. Thank you for taking the time to hear our bill, which is foundational to continuing to build the healthcare system necessary to meet the needs of Minnesotans, specifically Minnesota children who have been at the forefront of a mental health crisis that must be addressed. Before we get into the bill, I would like, Mr. Chair, to move the DE1, please, to get the bill in its most current version.
And I will move the DE1 amendment. Are there any questions to the DE1 to get the bill in the shape that the author would like it? Seeing none, all those in favor of adoption of the DE1 amendment, please signify by saying aye. 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 Opposed, say nay. The amendment is adopted. Representative Bierman, to your bill.
Thank you, Mr. Chair. This amendment does not include any major policy changes. It makes technical updates to streamline and simplify the mechanics of increasing reimbursement rates. I wanted to again start by thanking the DHS folks, Ms. Director Graume and Mr. Hayes, for presenting their outpatient rate study. That presentation gives us all a good grounding in why this bill is needed. House File 1005 implements the mental health and physician service components of DHS's study and increases a few other mental health rates not included in the study. I'll get more into the details of the bill components later. We all know that medical assistance, or MA, is critical for health care coverage in Minnesota. Nearly a quarter of all Minnesotans from every corner of our state rely on MA for their health care. This includes over 40% of all babies born in our state. And, as we just heard, reimbursement rates to providers who serve these Minnesotans have fallen woefully behind the cost of delivering care. Our current rates are unsustainable and have created a crisis in access to care. We have taken initial steps to implementing the rate study, and there is much more ground left to cover. Members, you have numerous letters in your packet from hospitals, community mental health providers, physicians, and diverse community partners that illustrate the magnitude of the problem we are trying to solve and its impact on all of our communities. We know that our system has reached a breaking point. Too many children and families are waiting weeks, months, or in some cases years to access the care that they need. When it comes to mental health, more and more of these children end up boarding in a hospital, juvenile detention, or with the county because families have lacked access to early intervention and intensive community-based care. We can fix this access to care crisis by increasing reimbursement rates while simplifying payment structures and increasing transparency. Now I'll turn it over to Rep. Baker to share some of his thoughts before I walk through the bill.
Representative Baker.
Thank you, Mr. Chair and members. I want to echo Representative Bierman's thanks again for this really important discussion today. You all know, for me, working on treatment for substance use disorder and mental health disorders is personal. Many of us have worked together to make a positive change on these systems over the years, and those changes have made, I think, a real positive impact. But foundational to the access issues we are experiencing are clearly now the low MA reimbursement rates that we're finding ourselves in. We'll continue to hear from testifiers today about the crisis of the boardings in hospitals and providers having to make tough decisions and about whether they can continuing offer these services or not. And to Representative Hicks's comment, how long the waiting lists are. These really matter right now. Mental health and substance use disorder providers are shrinking or closing their doors around Minnesota. because they cannot hire and retain staff. And more physicians and other healthcare providers are unable to serve those most in need because the cost of providing care has increased while reimbursement rates have literally remained flat. We did hear earlier this year, too, that 80% of children's mental health providers reported that they would likely have to cut their services or close their doors altogether in the next 6 to 12 months if we don't do something. These closures and shrinking services are felt especially in rural Minnesota, where access to health care has been a real issue for years. It's time to finally address the foundational issue causing the stress on our system. And also, members, we have to realize doing nothing this year is also going to be making sure that we're going to go backwards, because we have new employer mandates coming out with paid family medical leave that put more pressure on the administration side to make sure that the workers will have the ability to be there for our patients. But with paid family medical leave too, it's a good program. We need to support a version of something that will work. More providers will be out for probably a little longer time. We have to recognize that. So it all starts with good reimbursement rates, and that's what we need to do here today. The phased implementation proposed in this bill encourages us to think long-term about how we're going to solve this problem, because this is a major issue in front of us, and we all know that, because everybody sitting here wants to do something. But we don't have unlimited dollars. We have to think about this in a very planned, methodical manner. This bill also sits nicely alongside other bill that increases our substance use disorder rates as described in the DHS study. Both bills are urgently needed, and I'm glad to hear to support them and try to figure out how we can start this phased-in approach, Mr. Chair and members.
Thank you, Representative Baker. And I understand you have a few presenters for...
Well, I have a few more comments about the bill itself. Thank you, Mr. Chair. Thank you, Representative Baker, for your comments. Our bill implements the remainder of the mental health and physician services recommendations in DHS's rate study. This includes ensuring reimbursement rates for mental health and physician services that have an equivalent Medicare payment will be paid at least 100% of the Medicare fee and schedule, and increasing community-based children's and adult mental health rates and behavioral health home rates to the DHS study calculation, as these rates do not have an equivalent in Medicare. In addition to implementing these study recommendations, the bill also ensures the master's level providers are reimbursed the same amount as other clinicians when using the same billing codes, and increases funding for hospital inpatient mental health services delivered to fee-for-service Medicaid enrollees. These increases are phased in over 3 years. The first phase is effective January 1st, 2026, and increases mental health and physician service rates that have a Medicare equivalent, as well as all other children's mental health community-based services that don't have a Medicare equivalent. The second phase starts in 2027 and increases rates for all other adult community-based mental health services that don't have a Medicare equivalent, as well as increases rates for master's level clinicians by repealing their current cutback. The third and final phase is in 2028 and increases rates for behavioral health homes and fee-for-service hospital inpatient mental health services. These rate increases impact almost all outpatient providers, from mental health to physicians to APRNs to physician assistants. We are all well aware of our current financial forecast as a state, and this proposal requires significant state resources. This is why we've proposed a phased approach and are very much looking forward to continued conversations about what steps we can take this year and next year and the following year. Our provider communities and Minnesotans can't wait any longer. We now have 3 testifiers to speak to the impact of this bill. Please, Mr. Chair, we'll go to the testifiers.
All right, if they could please make their way forward. And in however order you wish to present. Welcome to the committee. Please state your name for the record and present your testimony.
Thank you, Mr. Chair and members. My name is Rolit Webedi. I'm Dr. Rolit Webedi, and I'm the president of Minnesota Academy of Family Physicians, representing more than 3,100 members across the state. I'm testifying today in support of House File 1005 on behalf of the Minnesota Medical Association and Minnesota Academy of Family Physicians. I'm a family physician practicing at the Community University Healthcare Center, a federally qualified healthcare center in South Minneapolis. Most of my patients are on Medicaid. I see them relying on medical assistance for their healthcare coverage to access primary care. The increased reimbursement rates proposed in this bill will improve access to care and advance health equity for all Minnesota patients in every corner of the state. In addition, it will help clinics throughout the state stay in business and avoid having to merge with larger systems. Ensuring access to primary care allow Minnesotans to access preventive care as well as ongoing management of their chronic condition. Investing in primary care by addressing the unsustainable medical assistance reimbursement rates help keep patients out of emergency rooms and needing hospital stay. Countless studies have demonstrated that investment in primary care ultimately saves the overall healthcare system money. Focusing first on access, the number of Minnesotans who depend on MA has grown substantially over the years. Today, about 1 in 4 Minnesotans are covered by MA, and more than 40% of the babies born in Minnesota are covered by MA. Unfortunately, there has not been an access across the board increase in MA rates in decades. Currently, MA reimburses 60 to 70% of what Medicare pays and only about 30% of what commercial insurance pay. These rates have fallen too far behind, and when rates can't keep up, services are cut. Communities are left without care, and patients suffer as a result. Just this past week, I took care of several patients who would have either gone to emergency care or not seek care at all without MA. It included a Somali young man with severe persistent mental illness who lives in a group home and has a diabetes but does not like checking his blood sugars. This past Saturday, I got a call at 5:30 in the morning that his sugars were 606. I spent several hours to control his diabetes over phone as he will only listen to us or the group home owner. During those hours, I was the pharmacist, I was the social worker, dietitian, psychiatrist, care coordinator, and primary care provider. I was able to provide excellent care managing his insulin, provided him education about food and diet, and also managed his psych condition. He was happy that he was not sent to the ER, which led to increased trust, good patient experience, and also reduced the total cost of care. It did not stop there. I came back to the clinic on Monday morning, and the first thing I asked one of the nurses to call the patient to check up on if he was taking his insulin. Having all these services is costly, but improve care significantly and reduce the cost, and current Medicaid rates do not cover the cost of all these efforts that our patients are needing in supporting their health. I also heard a story from our dental clinic. We saw a kiddo, 13-year-old last year, who came to the clinic and did not have any insurance. And she came to the clinic with a pus oozing from her chin. Was seen in the medical, was started on the antibiotic, and immediately was sent for an x-ray in our dental clinic. And it showed that one of her tooth was coming out of the chin, and that was causing the infection. We made a decision that she needed a maxillofacial surgery but did not have the insurance, and it took us several weeks, but we finally got her on the MA, and I was able to consult with the pediatric surgeon, maxillofacial surgeon, 1 year, and the school, and 1 year later she had the surgery, and her disfigurement of the face was avoided, and so her life is changed because of the MA. Increasing rates will also advance health equity. Currently, Minnesotans on MA are disproportionately rural and traditionally underserved areas. You have information in your packets pointing out which Minnesota counties have higher rates of patients on MA. These patients live in every corner of the state, and in fact, as a greater percentage of MA patients live in greater Minnesota. Increasing these rates will help ensure those in these regions, our neighbors and their kids, are not left behind. I'm privileged to be sitting here, but I know I have a lot of colleagues who provide care in rural Minnesota and all over, and a lot of them are at the verge of closing their services. Physicians remain committed to serving Minnesotans on MA. This program is critical to ensuring access to care for all Minnesotans. However, the failure to update reimbursement rate is forcing difficult business decisions for many services. It is time to update MA payments to at least the Medicare level. Thank you for the time today, and thank you so much for giving me this opportunity, and I'm happy to help answer any questions.
Thank you, Dr. Dvadi, for your testimony. Welcome to the committee. Please state your name for the record and present your testimony.
Thank you, Chair Schumacher and committee members. My name is Jessica Brisbois, and I am a licensed clinical social worker and the manager of acute mental health services at Children's Minnesota. I appreciate you having me here again to discuss what must be done to address the mental health needs of Minnesota kids. The crisis kids and families are facing continues to grow more critical, and solutions are desperately needed. There is a lack of mental health services in our state, and children are waiting for months to access care, often utilizing the emergency department as a last resort. In 2024, kids boarded at Children's Minnesota more than 1,200 times, a substantial increase from the year prior. This increase reflects the consistent trends we've seen each year since 2022. 77% of the patients we see boarding in our hospital and almost half of the patients served by our mental health programs rely on Medicaid, which is why increasing Medicaid rates is vital to addressing the challenges providers are facing. The parents and guardians of these children have often recognized their child's need for support, but have run into barriers accessing outpatient services, including long wait lists. While waiting, their child's mental health gets worse, which is what brings them to the emergency department. The last time I testified before you, I expressed my concern regarding the lack of access to the community-based services. This problem has continued to grow. We continue to see the capacity of mental health providers shrinking because of inadequate reimbursement rates. In order to remain safe and successful outside the hospital, children need outpatient mental health services. Currently, we cannot always guarantee access to these services, even for patients that are discharging from the hospital after a serious mental health crisis. This leads to more families returning to us after not being able to access appropriate care. These families are defeated and exhausted because the system continues to fail them. Across all of our mental health services, we are reimbursed for less than half of our costs, and as costs continue to rise, that level of reimbursement is getting worse. The current rates are unsustainable. On average, we operate these vital services at a loss, severely limiting our ability to recruit and retain staff needed to meet the growing needs of our patients and their families. This contributes to long wait lists and why most of our outpatient services are only available to current Children's Minnesota patients. One of the biggest impacts we can have on the mental health crisis is investing in outpatient care. That investment would decrease pressure on the rest of the system, including emergency departments, inpatient units, and other more acute services. Most importantly, it would give children and families a better chance of addressing their mental health needs. We all want to build a system where kids and families are never in crisis. We all want to see children be able to get the help they need when they need it. Foundational to doing that is making sure Medicaid reimbursement rates are adequate. We will not see meaningful change unless we take this step. Thank you, Representative Bierman, for your leadership on this bill, and thank you, committee members, for your time.
Thank you, Ms. Brisbois, for your testimony today. Welcome to the committee. Please state your name for the record and present your testimony.
My name is Julie Hannenberg. Mr. Chairperson, members of the committee, thank you for the opportunity to testify today. As I said, my name is Julie Hannenberg. I am an LICSW, and I am the founder and executive director of Lighthouse Child and Family Services. We provide school-based, school-linked behavioral health services, day treatment programming, and outpatient services across 10 rural counties in central Minnesota. In 2022, we were forced to close our in-home children's mental health program due to insufficient reimbursement rates. This decision has had a devastating impact on our rural communities, and it has significantly decreased access to care in an already underserved and impoverished area. We served a 4-year-old young girl named Sally. She was referred to us because she was expelled from childcare and Head Start and struggling to be safe at home due to her explosive behaviors. With in-home skills and therapy, Sally and her parents gained new strategies and skills and developmental supports that helped her stabilize and start to thrive in Head Start and at home. These low-cost, high-impact services helped preserve the family and supported Sally to become a successful kindergartner. Providing early intensive interventions does decrease long-term mental health crises and costs. Unfortunately, Lighthouse's closure is not an isolated case. The capacity for children's mental health services has decreased significantly across the region, worsening the crisis for children and families who urgently need early intervention and community-based care. In fact, a survey conducted in January revealed that 80% of children's mental health providers expect diminished capacity or program closures within the next 6 to 12 months. Current Medicaid reimbursement rates are often 40% below the cost of providing services, making it increasingly difficult for organizations like ours to hire and retain qualified staff. As a result, children and families are going even longer without the care they need to thrive. I am deeply concerned about the growing mental health crisis and the increasing inability to deliver timely and intensive services. House File 1005 represents a critical opportunity to address these issues by fixing reimbursement rates for mental health services. These rates are essential for maintaining the well-being of children and families. Without adequate funding, we risk further destabilizing our communities. However, with appropriate investments in reimbursement rates, we can stabilize and support the children and families who rely on us. Thank you for your time.
Thank you, Ms. Hannenberg, for your presentation, and thanks to you to all three for helping present on this bill today.
Thank you, Mr. Chair, and thank you, members.
Next, for public testimony, Dr. Steve Girardo. Welcome to the committee. Please state your name and present your testimony.
Thank you, Mr. Chair and committee, for hearing me today. My name is Dr. Stephen Girardo. I am a co-chair of the Legislative Committee for the Minnesota Psychological Association. I'm also the Federal Advocacy Coordinator representing Minnesota to APA and to the federal government. I am also Executive Director for Mental Health Systems, which we have 5 brick-and-mortar clinics in the Twin Cities, and we also provide outstate services through telehealth. I'm here in support of the bill, but I have a comment, an observation, and a part of the bill I have a problem with. The comment is that we are, of course, in a mental health crisis. There is absolutely no way that anybody can argue that there isn't a mental health crisis. This was in play for a very long time related to rates. It was exacerbated by COVID, which ended up closing a lot of programs that were for intensive services because they couldn't do their services during the COVID pandemic, and those services could not be afforded to restart. Anybody who's ever started a business knows you don't need just running expenses. You need running expenses for a number of months before you're actually going to be receiving income. So a lot of these programs are not being replaced. The bill actually does make steps towards trying to fix the problem. I think one of the committee members already mentioned that it's a step in the process. It's not a completion of the process. My comment is that the RBRVS system, it was identified by people from DHS as actually coming from CMS. It is not a CMS entity. It is a committee from the American Medical Association that serves, and it's a volunteer committee. And there are no behavioral health providers that are part of the committee that sets rates for the general outpatient codes. Now, for psychological testing and codes that are just for psychology, then there are psychologists there that are talking about it. But all of those relative value units are being determined by medical doctors, not by behavioral health specialists at all. And that's a problem that I'm trying to address and APA is trying to address at the federal level. But the data is underrepresents the actual costs of things because they're trying to determine what our costs are and they're not providing that same service. So I don't think we have a methodology to tie to other than that system right now, but just understand that that system is flawed and will underreport what the costs are for mental health services. And I'm not saying anyone's intentionally doing anything wrong, but the way the system is set up is flawed. And so I think that's one of the steps we need to look at later. And like I said, it's one of the steps that we're looking at federally as well. The opposition that I have is just in the repealing of the pay differential for doctoral level psychologists as opposed to master's level clinicians. And the reality is that pay differential, if you eliminate it, you basically are starting the process of eliminating psychology at the doctoral level as a profession, because you have to go to school for 2 more years of classes and 1 more year of in-person training before you start getting hours for your licensure. The cost of that schooling is more than double the cost of getting a master's degree to get a license as a master's degree, but you also lose 3 years of income. I've had students that have come out of our program that we do internship training. Part of our giving back to the community is we train interns and in social work interns and all those other licensures. I had an intern that I was supervising, and she said she and her husband made a decision not to have children because they couldn't afford to have children and have a house and move on with their lives, because they came out of school with $250,000 worth of debt to get the education. The current debt load coming out of medical school is less than the debt load to come out for psychologists. Why does that matter? One of the things that's been talked about, it sounds like it's equivalent service, so why aren't we paying the same? It's not equivalent service because the provider does not have the same level of training and education. I was a master's level psychologist back in the day. I've got the gray hairs enough to have been grandfathered in as a master's level psychologist. I went back and got my doctorate because I knew that there was more to know. And I got value for my additional 3 years of education and the money I paid for that education. And my clients got value for that. And I don't know anybody who could successfully argue that 2 more additional years of education classes and 1 more year of in-person training does not change the quality of work. Why this is especially important for this bill is that people on MA are the most complex cases that we're going to have in aggregate in our state. They're the most vulnerable people that need the highest level of services. They need doctoral level psychology. And as it currently stands, a lot of doctoral level psychologists are finding ways to pay their bills by going into the private pay industry, where they have somebody come in and pay them privately, and they can actually pay off their loans and do okay financially. I've not chosen to do that. I don't need lots and lots of money, but I need enough money to pay for our staff. And that is a staffing problem, and that we've heard testimony from other people saying it's hard to hire people. It's really hard to hire doctoral level people, and we do take MA and MinnesotaCare. And so we're working with those really complex cases. And so if we don't fund a difference in licensure, if we repeal the 80%, the 20% difference between the 2 pays, we're literally not going to have doctoral level psychologists. And the Minnesota Department of Health did a study a number of years ago talking about there just being a crisis in doctoral level psychology because we're not replacing ourselves at the rate that we're going. Currently, over 55% of psychologists are 55 and older. They all look like me and maybe a little younger, but if we don't fund the licensure, we're going to lose the expertise of psychologists. And I do understand that, the code is the code, but if we don't have a different code for doctoral level psychology that pays at a different rate, you can't change the payment rate and not have a really significant impact on our community.
All right, thank you, Dr. Girardo.
That's great, thank you.
All right, thank you. Is there anyone else who wishes to testify on House File 1005? Seeing none, public testimony is closed. Questions from members? Representative Backer.
Yes, thank you, Chair. Roughly, what type of price tag are we looking on this to raise the rates to be at 100%?
Representative Bierman.
Mr. Chair and Chair Backer, we did hear from the department on that it's in some hundreds of millions, but we are still waiting on the fiscal note. And so we're going to have to find out what that is. It'll be coming soon. And once we have that, then we will be able to dive in a little bit more to kind of determine, once we have the budget out and we know what kind of money we have to deal with, we can see how much of this we can take on this year. But I don't have a price tag on this whole three-phased approach at this time.
Representative Becker.
Thank you.
Representative Gilman.
Thank you so much, Chair. Curious if House File 1005 recognizes the rate study that we just got today on page 21, the behavioral health reimbursement rate. Is that included in this bill? Thanks.
Representative Bierman.
So on page 21, I don't have that report in front of me right now, but this behavioral health, if it's mental health, this one is dealing with the outpatient, as we described in the bill, for children, adults in this phased approach. So yes, behavioral health is being covered in this with Medicaid being raised up to the Medicare rates, which is really our solution to strengthen the entire continuum of care and address the shortage of access that we're seeing for children and adults across the system.
Representative Baker.
Thank you, Mr. Chair, and Representative Gilman, good question. Not really.
No?
But it's part of it. But Representative Bierman is not wrong on this at all. But again, I know that these two studies are but a lot of the SUD was included in this overall study. This bill is not so much addressing it as maybe others have seen. I think Representative Frederick might be working on sort of like the other March side of things, which really kind of comes around with that. So it is massive. And I think this covers a huge part of it. And the SUD side of things are off to the side. It's kind of, I think, walking a little bit in parallel, but I haven't had a chance to follow up with that one as much. But it's a great question. And this one is not all about the SUD as well. So that's another part of it later. Thank you.
Mr. Chair, the behavioral health, when I'm talking to people about behavioral health, it often is also encompassing both, because there's so much commingling of mental health and SUD. So behavioral health to me is that entire umbrella. And so if we want to talk SUD, that we can talk about that on its own, but we can talk about mental health on its own. But you have to realize there's a big section in the middle that it encompasses both. So, yeah.
And Representative Bierman, I just have to say, I kind of chuckled there when you responded, not so much at you or the response, but just how honest, because you don't see that around here as much. Representative Gilman. All right, any other questions for the bill presenters? Representative Keeler.
Thank you, Chair. I guess I don't really have a question. I more just want to make a statement and I guess a notion of gratitude for bringing this forward. Mental health in our kids is something that is massive. And I've sat in a lot of conversations, and I think I just want to recognize that it's not just about getting the services you need at that time. Some of the tables that I've sat at, particularly around ending homelessness, when we don't have the supports we need to address mental health services, it increases the likelihood that individuals become unsheltered. So this bill addresses that. Another table I've sat at a lot lately is around attendance and truancy. And when we don't support our kids at the highest level that they need, they miss school. And we all agree that kids need to be in school. And our school systems are saying our teachers and our schools are not designed to support the mental health needs that our kids are coming to school with. So we need to have these services in the community. The fact that 80%, I think is what I'm hearing over and over, of doors could close. Is that what you said? That's terrifying, emotionally terrifying for me as somebody who deeply wants to support inclusive, accessive care around mental health. But also, this is family preservation. We talk so much about keeping our families together and providing the needs that they have. Family preservation is saving lives, is keeping our kids alive, is making sure we have the birthdays and the celebrations that they deserve to have with us. And so really just coming forward as a bipartisan way to do what is right for our kids, I think is an example of how we can do this work this year. And I am just really grateful for you two stepping up to do this. And our kids really need this. And I think that I know we have little money to spend, but when we invest in the health of our kids, it's just so invaluable in the future. So thank you. Thank you, Chair.
Thank you, Representative Keeler, and Representative Bierman, Representative Baker, just to follow up a little bit more, I wanted a little more clarification on Representative Gilman's question there about what of this study is included in your bill under the DE1 versus what else might be out there. We have this whole rate model chart there in Appendix B. Could you just help kind of walk us through what is and isn't in there, if you're able to?
I have a list,
Okay, good.
I believe, here. Okay, thank you, Mr. Chair. And thank you, Representative Keeler, for your comments. I think I'll talk about a couple of those things when I close as well, but I appreciate your comments on this bill and the working together on this. What's included in the bill are behavioral health homes, OBGYN, primary care, physician professional services, outpatient mental health, that includes therapy for individual and family group, psychiatry, psychological and neuropsychological testing, assessments, CTSS, which we talked about, children therapeutic supports and services, the skills, the ARMS that was referenced earlier. So that's adult rehabilitative and mental health services, peers services, in-home therapy, marriage and family therapy, clinical counseling, crisis services. So those are all covered. And then in addition, the rate study recommendations, the elimination of the 20% master's level cutback. So master's level would be paid for the mental health services they are providing at the full rate. And then fee-for-service inpatient hospital mental health rates via rebasing. So that's what's included. There's a list of what's not included in this bill as well. If you'd like to hear that, I can read that down as well, but that'll be coming in the next one.
Okay. Yeah, if you could just go over that quickly, just so I can
Sure.
get organized.
So what's not included, adult day treatment, EIDBI, hospital, dental, pharmacy dispensing fees, EMS, SUD under 245B, residential treatment, withdrawal management, group treatment, behavioral health fund, sober homes, opiate disorder, SUD recovery, peers, SUD treatment coordination. And then we listed previously, we heard about some of the things from DHS that are on a different cost basis, FQHCs, CCBHCs, PRTFs, IRTSs, and ACTs, CRFs, and Indian Health Services, IHS. I can spell all those initials out too, if you like. Those are all, certified community behavioral health clinics, psychiatric residential treatment facilities, intensive residential treatment, and assertive community care and treatment. So a long list on both sides. We're doing a lot. The next bill will cover a lot of those other sides to that. But it's comprehensive. It needs to be, because we have a need that is great, that has been getting larger in all the years I've been up here in the legislature. And it's time to really take a big step forward.
Thank you, Representative Bierman, and thank you for that list too. It's helpful just to understand, just kind of, this gives us the full scope of what they were able to do, and then to correlate that with the bills and the buckets that those are all trying to work with here. I think that makes sense. So that was very helpful. Representative Fisher.
Thank you, Chair Schumacher, and thank you, Representative Bierman and Baker, for doing all the work on this. I know this is an area where we've had very strong bipartisan support over the years, and I think it's something that it's really nonpartisan. We all agree, and everyone in this country agrees, that we need to do more to help build up our behavioral health system out there. The question I've got, because I know we talk a lot about the Medicaid rates, getting those changed. When I take a look at Section 5, though, I notice that we've got dollars specifically called out for inpatient behavioral health services. I'm wondering if those, and this might be one more for the department, is I see $10 million in fiscal year 2028, $10 million in 2029. Are either of those amounts able to be offset at all by the Medicaid rates with federal match, or is that all just going to be just straight the $10 million from the general fund?
Who would like that?
Let's just
Representative
get the department up to confirm that question. I think that would be wise if they would come up.
You can see why I'm asking the question. Mr. Race, welcome back to the committee.
Mr. Chair and members, usually with language like that, we assume that there's a federal match, so it'd be $10 million in aggregate spending. So we would spend an additional $10 million. Some of that would be federal, some of that would be state.
Representative Fisher.
Thank you. So, thank you, Chair Schumacher. Thank you. So, if we spend 10 million, then another 10 million from the feds will come in, or we're going to spend, the 20 million in total, but 10 of that will come from the feds.
Mr. Race.
Mr. Chair, we're going to spend 10 million total. So if you were to really, really simplify the math and call it 50-50, although that is really oversimplified, it's going to be 5 million from the state general fund and 5 million from the federal government.
Okay.
But again, usually it's closer, more like a 60-40 when you blend everything together.
Representative Fisher.
Thank you, Chair. Thank you so much. That's kind of what I thought, but I didn't want to make that assumption. Thank you.
Any other questions for House File 1005? All right, final comments, Representative Baker, then Bierman.
Yeah, I'll go first, Mr. Chair. Thank you, members. I just want to thank Representative Bierman for kind of leading the charge on this. We have done a lot of discussions about this, even during the interim. And when it came for this year, kind of knowing the layout of our makeup this year, we knew that the more we did together like this, I think the more we're trying to recognize the importance of it for what it is. This is a huge nut. I'll say a number because I asked the number offline, and it's around $350 million. If we had it all today, that's what it would take. Now, we're asking for a phased-in approach on that. Now, I don't know how close it is, and I'm not going to get quoted either because nobody's going to care what I say, but they care what the department says. But I think as I ask that question, we're thinking at 150 million for phase one, give or take. I don't know. But this outpatient services is really key, as you heard earlier, to help people early on when they can still function and be home, and to save more workers that'll stay out in rural Minnesota so our centers are not closing. This is a big deal, and I've heard about this since the day I walked into the legislature 10 years ago. All of my work with the opioid stuff and the ORAC, the Opioid Advisory Council, we talk about this and we see this, and it's crippling us because the great work we have done here in the last several years is only going to go to waste if we don't have people there to take care of them. And if we don't keep up, and if we don't keep up with the things coming at the operators and the centers, again, workforce rules matter. Workforce costs matter. And it comes right down to this. If we can't keep up with the MA rates and Medicaid rates, we are going to lose all of our advances that we've done over the last few years. So I know this is hard to ask for. It's a lot of money. But when you want to get serious about mental health, substance use disorder, it's going to start with a bill like this. And so I just appreciate the work ahead of you all and all of us and the hard decisions that are in front of all of us. And again, Representative Bierman is a champion on this, and I'll work with him as long as he'll have me around. But again, I just know this is a bipartisan problem that we need to get our arms around. So thank you, Mr. Chair and members.
Mr. Chair, just want to thank Rep. Baker for all of his work. He's been diligent from the day I met him and the first day up here, and just appreciate the good work and the solid approach he takes to taking all of this very seriously, very thoroughly, and finding the best solutions for the state of Minnesota. We had Dr. Royley up here earlier. Hopefully you don't need to come up. I just wanted to comment on a conversation we had one day regarding where you work in the FQHC, and you made the comment that the healthcare issues that you deal with, rates affect all of that. It affects your ability as a primary physician. It affects your ability to hire workforce. It affects your ability to truly treat patients before they disappear and go to the emergency room for care instead of being treated as you can so aptly treat them. So rates affect everything. And when we don't have the services in community, what happens? Patients don't get the care they need, their conditions become more chronic and difficult, and they end up in the emergency rooms. If you've talked to your local hospital, you've heard about this. This is a serious condition that is not getting better, it's getting worse, and we need to deal with it now. And I think that the other side of this is schools, you know, if we aren't treating kids in school, or at getting them treatment either in a day program that I visited a couple of years ago, which has now closed, by the way. They were taking kids to that day program, getting the mental health treatment that they needed, and back to school and back and forth, and they were getting the services they needed. They are no longer, and that was in a urban area very close to my home. So they are closing. The enormity of the problem is getting bigger. You have all signed up for this committee, so you get to be helpful in the solution, and this is the year to address it. So thank you for your work here, thank you for being here, and thank you for your consideration.
Thank you, Representatives Baker and Bierman, for presenting on House File 1005 today. With that, House File 1005 is laid over for possible inclusion in a future omnibus bill.